afternoon, everyone, and welcome to the Yale Sleep Medicine Grand Rounds and part of the weekly sleep seminar. My name is Clara Yagi. I am one of the faculty in the section of Pulmonary Critical Care Sleep Medicine and the director of the Yale Center for Sleep Medicine. As per usual, just a few brief housekeeping announcements before we get started. Please ensure that you are muted. In a little while, there will be in the chat instructions for receiving CME credit for your attendance today. You'll need to sign up to receive credit. I will be moderating today's session. So if you have any questions or comments during the presentation, please go ahead and just put them into the chat and we'll get to those questions towards the end of the presentation. And as always, we will have recorded versions of this lecture and all our other ones on our YouTube channel after the presentation. So with that, I have the distinct pleasure of introducing Dr. Jennifer Langstengel, who is one of our esteemed sleep medicine fellows here at Yale, and she'll be delivering today's sleep medicine grand rounds. Jennifer is no stranger to Yale. She completed her pulmonary critical care medicine fellowship training here and decided she hadn't had enough of it of us just yet and stayed on for her sleep medicine fellowship. She completed her medical school at Geisinger School of Medicine in Pennsylvania, followed by residency and a chief residency at the University of Iowa. During her fellowship training, she was honored as a recipient of the ATS Aspire Fellowship, which is an excellent program that supports pulmonary and critical care fellows who have an interest in sleep medicine and sleep research. Jennifer is a seasoned clinician whose career has tackled everything from ventilators and opioids, and she'll be speaking about that today, to even case reports and talks about coral-induced hypersensitivity pneumonitis. Yes, that is actually a thing that I had never heard of. She is able to combine rigorous science and genuine compassion for her patients. And I think she may be the only sleep fellow we've ever had that can say VEGF-R2 plus endothelial progenitor cells without needing a nap after saying that. So let's welcome Jennifer to her presentation. Take it away, Jennifer.
Awesome. Thank you so much for that introduction. And what I'm going to talk about today is sort of the culmination of a project I was very lucky to sort of get involved with as a first-year pulmonary and critical care fellow when I showed up for a sleep clinic as 2 months into fellowship and went, I don't know what I'm doing and I don't know what I'm doing here. And Dr. Yagi sat me down and went, let me tell you about sleep medicine. And I fell in love with the field right then and there. What I'm going to talk today, we're going to kind of jump through a few different domains, but really I want to talk about sleep and the battle against opiate use disorder, which is a really hot topic, both in the world of substance use disorder and addiction psychiatry, as well as within the world of, pulmonary and critical care medicine, where we are dealing with so much of it as well. So how today is going to kind of go, we're going to do some background. We'll talk a little bit about sleep circadian biology. We're going to talk about what does sleep look like across the trajectory of opiate use disorder. And then we're going to talk a little bit about bidirectional mechanisms between sleep deficiency, a little bit about the construct of sleep control, which is the sub area that I work within, and then talking in exciting news about some novel therapeutic targets that are emerging within the field of sleep and substance use. Here is the CME slide. I have no disclosures. Debbie is also putting this in the chat. Okay, so for a little background and context on OUD. I know a lot of us here, we come from different backgrounds. My personal background was primary care, internal medicine, and then pulmonary and critical care. So, I think this is really not shocking to really any of us, but the opiate epidemic in the United States really has been skyrocketing, although this was just published recently. Fentanyl deaths have come down a bit recently, which is very, very exciting. But really, especially during the pandemic, there's just been this exponential rise in opiate related deaths. There's been multiple waves. So people often talk about the different waves of opiates. Sort of, we had the original heroin, then we had the commonly prescribed opiates. So this is sort of what you think of when people talk about the Sacklers and the OxyContin and all of that. That's sort of in that category. Then we moved over to synthetic opioids. So that was the rise of fentanyl in particular. And now the super potent like carfentanyls and things like that. And so this is sort of where we are, which is a really terrifying point. And it's been declared a true epidemic in the United States by the Surgeon General. For Connecticut context, Connecticut mirrors the rest of the country. I think it's always important to see what things look like locally in our area. But when you look at into 2012, there were 350 overdose deaths, and in 2021 there were 1,500. There was also a rise in cocaine within these, which is thought to be because a lot of the cocaine is contaminated with opioids. So it's a pretty bleak thing, and so the question that everyone sort of rises is how do we treat opiate use disorder? Because I think a lot of us know many patients with opiate use disorder want help. And they want to get better. And so, how do we do this? And really, opiate use disorder is a complex thing to treat. But medication for opiate use disorder is standard of care and is considered best practice, and it needs to be given as part of a comprehensive treatment plan. The three sort of commonly used medications are methadone, buprenorphine, and to a much lesser degree, naltrexone. Methadone and buprenorphine are the two most common. And so those are used in combination with psychosocial and behavioral therapy to really help the person, come back from opiate use disorder. These are very old therapies. Methadone has evidence in opiate use disorder going back to the 1970s. So this is not it's not new, but it is where most of the evidence is. And I think what's interesting though is to know the efficacy of MOUD, where you're talking about really, they still are not extremely efficacious. And so this is just important to think of. If someone goes on methadone, to say, okay, you started methadone, I think you're going to be sober for the rest of your life is not a realistic expectation and would not be evidence-based to do. So the question is, what can we do to better help these patients achieve sobriety and to decrease deaths from overdose? So sleep and OUD. So we know that there's treatment for opiate use disorder. Relapse rates are high, about over half, often 2/3 of patients relapse, and they really don't retain in treatment, and they end up in this chronic cycle of illicit opioid use. So there's the one thought that came out of this was to really start to target the neurobiologic system that may be linked to relapse. And so sleep and circadian system was identified back in 2018. The FDA reached out to patients and said, what are some things you think would be helpful? And they brought in content experts and other people. And really sleep disturbance came up as one of the most common areas to talk about and to address. And that's sort of where some of this interest and the biologic background of these thoughts of sleep and opiate use disorder came from. When you think about it, the history of sleep and opiates really goes back like Morpheus, the Greek god of dreams, where morphine was literally derived from, and Hypnos is flying with Nyx, and they're spreading poppies to literally induce sleep. So there's this real historical reference going back for centuries here. So sleep deficiency and the trajectory of opiate use disorder. I think it's important. And I think a lot of us, there's a lot of things that you would sort of say, oh, that kind of makes sense in what you think of, but there's also some parts of the sleep in this disorder that are less, are different than what you would expect. So, we all know what sleep deficiency, there's sleep deprivation, there's non-circadian sleep, and there's all poor sleep quality here. And so this is sort of what sleep deficiency across the opiate use disorder trajectory looks like. So people start out, they're often doing medical or recreational use. They end up with social jet lag and delayed sleep phase. That makes them actually have increased vulnerability to addiction and misuse. So they enter into the cycle of misuse. Then they develop addiction. When patients undergo withdrawal, they have marked sleep changes. So their sleep latency increases, their total sleep time decreases, their sleep quality decreases. They also have a lot of physical symptoms as part of their withdrawal. Once patients make it to recovery, about 90% of patients report very poor sleep quality in their recovery program. And so what happens is the patient will then often relapse. They can often overdose, and then they end up, unfortunately, dying in that cycle. Most opioid-related deaths occur during sleep. They're related to respiratory failure, where opiate-induced respiratory depression, sleep-related loss of respiratory drive, and the loss of the protective mechanisms that control breathing kind of all co-occur. And so this is something that sleep deficiency and sleep disturbance related to opiate use disorder is a very important domain within opiate use disorder for us to be investigating. And so it's thought that there's this bidirectional mechanism between sleep deficiency and opiate use disorder that's occurring. And so we know that there's a lot of evidence on what opiates do at what point. And sort of the question is, are they in acute use or are they in chronic use? So obviously sleep disturbance, we know that REM sleep latency is increased, sleep onset latency, REM sleep is decreased, slow wave sleep is decreased, N1, N2 is increased because you're decreasing N3 and REM. Wake after sleep onset is increased, the arousal index is increased, and next day perceived sleepiness. And so acute opiate use basically increases your wake time, reduces slow wave sleep and REM sleep. And this is seen in a dose dependent manner. And this is mediated via inhibiting sleep promoting neurons in the ventrolateral preoptic areas of the anterior hypothalamus. And so we know that acute opiates significantly impair sleep. It is more mixed in the chronic use picture. So it is less clear in chronic use patients, but certainly they don't just put people to sleep and put them into high quality sleep. That's certainly not the case. And so in addition to impairing sleep, opiates directly inhibit three major components of the ventilatory control symptoms. So the cortex, the pons, and medulla. And so the function of these components decrease with sleep and thus is further impaired with the addition of opiates. And so this results in several different forms of sleep disordered breathing as well. And so biat's respiration or ataxic breathing with opiate use is one. And so it's an erratic ataxic breathing pattern characterized by bradyapnea and a significant variation in depth. This is dose dependent as well. And so this is one of the common breathing patterns that's seen in opiate use. And this is just showing their AHI when compared to their opiate doses. And so the milliequivalents or milligrams per day, that's morphine milliequivalents or the morphine equivalent dosing. Sort of in opiate literature, everything goes back to a morphine equivalence. That's the standardized currency because every opiate has different dosing. And so that's sort of the common currency used to compare. And you can just see that as their morphine equivalent dose increases, so does the AHI. And so, now where does that leave us? Well, sleep deficiency is basically, we know that opiates, I just told you all about how opiates make you sleep deficient, but there's also, it's bidirectional. And so there are mechanisms by which sleep deficiency lead to opiate use as well. And so sleep deficiency is present in 65% of patients with OUD. It does not improve with MOUD treatment. And so we know that, as I said, like opiates have negative effects on lots of different parts of sleep, including your architecture, wakefulness. But what you can see is sleep deficiency also increases your perception of pain. It lowers mood, and it increases chronic stress. It increase your salience is increased and your negative emotionality are increased. And so this is leading to the person then craving and using more opiates, and then they're further impairing their sleep. And so they end up in these terrible loops where they're escalating their opiate dose, their sleep is getting worse, and they're caught in this terrible cycle. The other area that's been very actively being studied right now is the overlapping neural pathways in sleep deficiency and addiction. And so basically, we know that the prefrontal cortex, the extended amygdala, and the basal ganglia are all impacted by repeated drug exposure. Sleep deficiency actually impacts the same domains and circuits in a somewhat similar manner. And so the thought is that this is acting in a very similar way. And this is where some of the idea of starting to, you have to treat the sleep as part of the substance use disorder treatment to see if we can truly make a more durable response. The other thing is pain. Many patients who have chronic pain will say that their pain escalates during the night. And so we know that sleep deficiency, especially of N3 sleep, produces hyperalgesia. And then the problem is, as I said, acute opiate use also reduces your N3 sleep. And so patients are basically being set up in this cycle where they're having impaired sleep, and then that's increasing their pain. They're using more pain medication. This is particularly important in women. Women are more likely to take prescription opiates without a prescription to cope with pain, and they're more likely to misuse prescriptions for pain in particular. And so this is thought to be an important pathway to be studied in both sexes, but in particular women. So this all led to the NIH HEAL initiative. This was, I think, the biggest NIH initiative ever put together. And it was the NIH helping to end addiction long-term. And it basically, the thought was to improve prevention and treatment strategies for opioid misuse and addiction, enhance pain management. And so they did 6 teams based on scientific topics, and then with the goal to basically approach addiction from novel ways and to come up with other factors that could be contributing and just sort of cause people to think outside the box in new ways to help improve these patients' quality of life. So it was over $2 billion in total. The National Heart, Lung, Blood Institute got about $26 million, of which Yale received a grant under what's called the CLOUD study. So it's the collaboration linking opiate use disorder and sleep, which has 3 large aims. Overall, one was looking at neurocognitive connectivity patterns, looking for neural fingerprinting of ongoing opioid use using fMRI. The second aim was looking at biologic, psychiatric, and pharmacologic mechanisms between sleep deficiency and opiate use, looking at known OUD risk factors. And 3 was social and ecologic factors, neighborhood contextual factors that were thought to be contributing to sleep deficiency among patients with MOUD. So CLOUDS is an observational study, no intervention behind what patients would receive as part of their ongoing substance use treatment. It was conducted at 3 sites. It was psychiatry was one of the main partners, and that was through the APT Foundation and we worked with the West Haven, New Haven, and North Haven APT Foundation sites. And so basically patients showed up, they got presented to enroll onto medication for opiate use disorder. They would either get screened at the time they were joining and presenting to begin treatment, or shortly thereafter they would get contacted. They would undergo a large baseline assessment
and they would get followed for 6 months. And the primary outcome was looking at percent days with illicit opioid use, which was self-report as well as weekly urine drug testing. Within this, I looked specifically at the ability to control sleep environment, and to basically determine the degree to which control over sleep is predictive of recurrent opioid use. And so I used a measure called the BRISC, or the Brief Index of Sleep Control. It's a 4-item Likert survey. It's designed to assess self-perceived control over sleep. It has high reliability and construct validity. It is novel. It is validated in diverse population. It was validated in the SHADES population, which is an NHANES cohort outside Philadelphia. And so scoring is from 0 to 4, with a higher score representing increased sleep control, and a 1-point increase in BRISC is associated with better sleep quality, decreased daytime sleepiness, and decreased insomnia, even when adjusted for work hours. And basically, this concept reflects the degree to which individuals feels that their ability to control their sleep is under their control, or is it outside of their ability. And so this is sort of how we sort of looked at sleep here. So this is our person sleeping at the bottom, and you have their individual level factors, which is genetics, but also beliefs, attitudes, their overall health choices, things like that. At a social level, you have everything from their neighborhood, socioeconomic status, who's in their social networks, things like that. And then at the societal level, you have everything from public policy, racism, discrimination, natural environment, things like that. And so on this side of your screen, you can see all the different scores that we were assessing. So neighborhood violence score, measures of social cohesion, walkability. Did people live in a food desert? What was their safety score, the aesthetic quality? We did measures of family function, support from family within the home as well as outside the home. What was the size of your social network, the diversity of social network, childhood trauma measures, and then pain, resilience, catastrophizing of pain measures, as well as perceived stress and chronic pain assessments. For how did we measure sleep, we did an in-lab PSG. They also wore actigraphy watches for 2 weeks, and they kept sleep journals. We then did a variety of validated sleep questionnaires, including the Epworth Sleepiness Scale, the Pittsburgh Sleep Quality Index, the Insomnia Severity Index, and the PROMIS, as well as the BRISC. And so where did that leave us? Well, we enrolled 220 patients. We've completed follow-up. We actually have a very low rate of attrition of under 10%, because our research associates are on site at the foundation where patients are coming in for treatment. So we did not add anything burdensome to the patients. Basically, what this came out to, our population was about 40% female, which is good. It's actually known to be difficult to recruit women for these studies. We're about 78% Caucasian, and about 75% lived in their own home or apartment, with about 10% being homeless and 12.5%, which is other, which has been kind of interesting. Most of them live with someone, and 2/3 have a high school education or less, and about 1/3 of the patients were working. 1/3 of them referred to themselves as unemployed. So here's our baseline BRISC score. If you remember, a lower BRISC score is less ability to control sleep, and 2 is the cutoff. 4 is the maximum of the scale. And so we were kind of struck by how low sleep control scores. The median score was 1.25, which is what we were looking at, because this is not normally distributed. And so that's really representing how little control these patients have over sleep. From the validated literature, 0 to 1.49 is considered low control, 1.5 to 2.99 is some control, and 3 to 4 is high control. These are nominal cutoffs. They haven't been validated in a patient population, but it is definitely a sign when you look at the median for our patients that is incorrect. And now here's some of their baseline sleep data, because I think this is interesting. So 2/3 of our patients had evidence of insomnia. Only 25% had evidence of excess daytime sleepiness with an Epworth, based off the Epworth score, and 60% had poor sleep quality. So definitely not a patient population with normal sleep, and definitely symptomatic to their sleep symptoms. This is our primary outcome. And so this is sort of how many of these patients did relapse during treatment. Approximately 1/3 of the patients were not using illicit opiates at follow-up. 2/3 had significant recurrence. Of that, about 1/3 were using 10 to 50% of days, and 1/3 were using half of days or more. And so the vast majority were using like a little over like 10 to 20%. And they have on average a little over 35 days of 180 days in the study that they are using opioids. And so this is percent of days with illicit opioid use. We call it illicit because these patients many of them are on methadone, and that is a prescribed opiate. And we classify that separately. So you're like, okay, this looks not great. You already told me they have poor sleep, and they're all still, many of them are still using opioids. So the question is, does this measure of sleep control add anything to this questionnaire? And the answer is, sleep control is correlated with this. So a negative correlation is the higher the ISI, which is worse insomnia, the worse the patient's sleep control is. So it does seem to fit with that. And it's the same with the PROMIS. Higher the PROMIS, the worse the patient's sleep control. And the higher the PSQI, the worse the sleep control. Increased sleep duration was associated with increased sleep control, which also kind of clinically makes sense when you, I think when you think about it. Epworth was not correlated. So these are the demographic factors that we adjusted for: sex, race, residence, education status, if they lived with others, and their employment status. We then looked at potential mediators. So we looked at factors significantly associated with risk and viewed them as potential mediators, and we're looking for maybe if there's mediating pathways that are causing interactions that we're exploring with. One that we're very interested in is physical health, looking at the physical health score as compared to sleep control. And I have that data right here. And so basically, this is based off of the WHQOL BREF domain 1, which is a 7-item self-report survey about a person's perception of their health. And so basically a higher score on that is associated with higher health, like overall better quality of life in their physical health domain. And 14 is kind of the cutoff that is used for this. And so what you can see is for patients with poor physical health, risk is not significantly correlated. However, for patients who have a good physical health, the ability to control their sleep environment is correlated with their relapse for opiate use disorder. And so that's actually really interesting and something that's never been seen before. And so the question is, so in some of these patients who are overall physically doing well, is the ability to control their sleep environment potentially important to look at and monitor in talking about their opiate use disorder? We're not sure. We're still doing a lot of analysis. We're making our final models right now. But this is certainly pretty exciting to sort of be seeing. And then I think the next thing to talk about is, treatment for substance use disorders across the field is changing, and there's a ton of exciting work going on right now. And so where we're sitting right now with opiate use disorder and the options we have is probably not where we're going to be sitting in 5 years. And I think that's really wonderful for both us who are treating these patients, but also for the patients and their families. So I want to talk about some therapeutic targets. One, CBTI. I think we're all required to talk about CBTI, as we all know. But there's actually there's a few studies on CBTI in OUD, and so it really did show has shown promise for OUD and other substance use disorders, but it's very small. And I think it's going to be access to CBTI is already very difficult, and you're taking a patient population who historically has a hard time accessing care, and I think it's going to be difficult. But I think working it into treatment programs could potentially be an area upcoming. But CBTI has gone digital with apps and telehealth and things like that. So I think it's something to consider if you have a patient in front of you. CBTI does have some evidence. Pharmacotherapy, trazodone, no improvement in MOUD. Mirtazapine versus zolpidem. Mirtazapine improves total sleep time when compared to zolpidem. Melatonin may improve sleep quality. Quetiapine, it's not uncommon for patients to end up placed on atypical antipsychotics, especially if they're in dual diagnosis treatment programs that are also potentially addressing underlying psychiatric illnesses. But quetiapine may reduce some of the insomnia, craving, anxiety, and somatic pain. So it's occasionally used like that. Suvorexant. I'm going to talk about the DORAs in just a minute, but very exciting. And so improved total sleep time, REM time, and reduced opiate withdrawal severity and craving when used with a buprenorphine taper. And so this was very exciting when this came out. And it's a very difficult area to use medication in, because you want to avoid medications with addiction potential. And so there's a real concern about what we can use in these patients that won't cause them to develop sort of replace their current addiction with a different medication. The orexin hypocretin system, I think many of us know about this, but orexin producing neurons in the lateral hypothalamus. Decreased orexin causes narcolepsy, increased orexin causes arousal. Orexin neurons project to the reward associated brain regions. And so there is preclinical evidence that blocking these neurons attenuates withdrawal and drug seeking. And so these were identified back, if you remember when I talked about the HEAL initiative, there was this big FDA meeting in 2018, and DORAs were actually listed as one of the top targets for treating addiction coming up. There is thought that they have lower abuse potential, lower dependence. This is a very attractive option. There are some studies that are ongoing. Unfortunately, a lot of them were launching right when COVID hit, so a lot of them got very delayed because of that. But these are going on, and there's also been a couple of sort of large pieces written in some of the addiction psychiatry journals about this, and there have been use of mostly suvorexant, which is also sold under the brand name Belsomra in this patient population. Most of the other DORAs have just not, they're too new to have really been studied in this specific area. I think the drug that we're going to be most surprised to see is GLP-1 receptor agonists really have the potential to make major gains in this area. And it's funny because I think 2025 is the year that everyone in sleep medicine is just going to be prescribing GLP-1s, but it's truly, we're there. So GLP-1 receptor agonists, they reduce addiction-related behavior, both in animal models and in so mice, rats, non-human primates, and there's an emerging body of evidence in human trials that support this. There have been studies on alcohol, psychostimulants, opioids, nicotine use. The predominant evidence right now is in alcohol. with probably the second most amount of evidence related to nicotine. And most of these have not been using probably the medication we most commonly prescribe, which is tirzepatide, but these have been with liraglutide, which is an older GLP-1, and then some of them have been with semaglutide, which is sold under the brand name Wegovy or Ozempic. But there are preliminary clinical studies supporting the safety and potential efficacy of GLP-1 receptor agonists in addiction treatment. And so this is very exciting. Basically, it's thought that the modulation of a glucagon like peptide 1, which is a gut-brain peptide produced in the L cells of the intestine and cleaved by a pro-glucagon protein in the periphery, is primarily expressed in the intestines and pancreas. But there's a high expression of that gene in the central nervous system, primarily in neurons of the nucleus tractus solaris, as well as the intermediate reticular nucleus and the lower brainstem. And so these actually target brain regions associated with feeding, such as the hypothalamus, and the reward areas like the nucleus accumbens and the ventral tegmental area. And so, so the real thought is that this is really exciting and have the potential to work for patients very significantly. And so right now, where we are is preclinical studies suggest the drugs modulate these pathways. They reduce cravings, they influence stress response. Clinical research is limited. So there's been so far, the largest study I read thus far was just published in the fall. It was published in JAMA Psychiatry, and it was a study in Denmark of about 300,000. It was a retrospective database study of patients with alcohol use disorder, and it did show a very, very significant benefit for patients who are on GLP-1 receptor agonists who in reducing their alcohol use disorder related hospitalizations, which is a very big deal. And what's interesting is the traditional therapies we use for alcohol use disorder were not really just not very effective at all, but semaglutide was shockingly effective when compared to those. There's also been studies of patients who were on these drugs for other things where they were doing alcohol monitoring, like with the Audit C, which is a very well validated survey, that patients were like, yeah, I don't crave alcohol anymore. And I think conventionally, many of us in practice have seen patients who go onto these drugs and they're suddenly like, I stopped smoking, I stopped drinking. And so there's certainly, it seems to have a significant effect. So this is a novel mechanism targeting metabolic and neuroendocrine pathways rather than direct neurotransmitter modulation. They have an established safety profile. These medications are not for everyone, but they are by and large a very safe and treatment option. There are some concerns about long-term effect. I think the other issue is we all know that GLP-1 drug access remains to be a very big issue. And so really large-scale trials are needed for refining dosing strategies and to confirm benefits. But they certainly could hold significant potential for us. So sort of to sum everything up, opiates have negative effects on sleep architecture, including increased wakefulness, decreased total sleep time, decreased sleep efficiency, decreased slow wave sleep, decreased REM. Sleep deficiency is common and severe in many patients with OUD. It's bidirectional. Increased opiate use leads to increased sleep deficiency, as well as sleep deficiency, increasing pain, leading to increased opioid use. Sleep control is one such ecologic factor associated with OUD that may contribute to sleep deficiency, and novel therapeutic targets for sleep disturbance in OUD is an exciting area of development with the orexin antagonists and GLP-1 receptor agonists as major areas of clinical focus right now. And I just wanted to thank everyone on Clouds in particular, especially our amazing statistician, Sanjun, who explains many complex statistical models to me, and of course, Dr. Yagi. Right. Thank you.
All right. Thank you, Jen. for that tour de force overview of this complex relationship between sleep deficiency and the epidemic of opioid use disorder. And I would encourage folks, if they have any specific questions, to go ahead and put them into the chat. I think just a brief comment, and it looks like we have one question in the chat, that I do really believe that this is a space, and your talk sort of reinforced this, where sleep and respiratory neurobiologists can make some contributions to the epidemic of opioid use disorder. We can get more into that in a little bit, but the first question is from Adi. Thank you for this wonderful presentation. I appreciate the operationalization of your model. I saw this information on your flyer. Sleep control is a modifiable factor in reducing illicit opioid use and relapse. Can you please clarify this? I'm wondering how feasible and comforting it would be to employ sleep as a modifiable risk factor to reduce opioid use in people who have developed tolerance to opioids or people who have already experiencing hyperalgesia and pain. Can you comment on that, Jen?
Okay, one sec. I'm trying to pull up because I was trying to read the question, then I was like, oh no, I'm going to stop screen share. Sorry, so I can actually see questions. Okay, there we go. I think our hope is that it is a modifiable risk factor. I think right now where we are is we're still honestly at the stage of we're recognizing and we think that sleep is potentially something we can modify. I think recognizing and saying, I can fix this person's sleep, because we know even patients who've had achieved long-term sobriety, those still on OUD are still having sleep deficiency and sleep architectural changes. So I think we are not quite certain what chunk of their sleep is abnormal. I do think that we know for patients who we've helped with their pain, and there is evidence from cancer-related pain, that if you help fix their sleep, their pain perception does improve and their need for acute pain medication during the night goes down. So that there is evidence for. I think the question is, how do you do that in a patient who's on MOUD for fentanyl? That's a very difficult, who may be living in a sober house where they don't have a lot of control over their sleep environment. I think that's the part that we can. I think if everyone lived in like ideal living situations and did exactly what we said, I think that would be a more easily modifiable. I think the hope is that it will be modifiable, but I think that are people using DORAs for patients with OUD outside of research? Right now, not officially, no. I don't think anyone. I have had at the VA, I've had patients who have significant insomnia and who are on treatment for OUD, and I have reached for DORAs in them first in those patients. And I actually, not all of them have, but two of my patients who've had historically very high opiate needs, both actually really liked the DORA. That's daridorexant at the VA right now is their preferred DORA. And they both had very positive responses, but that's like an N of 2. But I think in general, because DORA coverage by insurance is so sporadic and you're often required to use the random insurance list of like failing everything else before you can get it. It's right now, no, it's not an approved indication.
I think there is, just to comment on Parvati's and the initial question and in response, I think that the HEAL initiative was really all hands on deck approach to look at novel mechanisms that contribute to opioid use disorder. And I think these connections that you so nicely outlined, Jennifer, between pain, sleep, and opioid use escalation, some of the same domains in the brain that are involved in addiction and sleep deficiency. I think that the hope is that by targeting this may help with craving. This may help with addiction tendency, and it's a neurobiologic system that really hasn't been well explored, and some compelling data that it can worsen outcomes among patients with opioid use disorder. And Steve Baldessari and a group of us at Yale have an ongoing trial looking at DORAs and among patients with opioid use disorder. They're not off patent yet. Suvorexant in particular, that comes off in a few years, and I think they'll make them much more affordable in this population. But to be able to treat both their addiction pathways and their sleep is really compelling, and it's a non-benzodiazepine too. I think that's and you made that point very nicely, Jen. What can you, while we're waiting for additional questions, what is your understanding of some of the therapeutic options regarding, because it sounded like, in addition to poor sleep quality, some of that is being driven by sleep disorder breathing. And some of the medication for opioid use disorder, methadone, buprenorphine, may themselves be contributing to sleep disorder breathing. What are some of the PAP modalities specifically that have been explored for treatment of sleep disorder breathing population?
Oh, wait, I have my slide on. Oh, did I not? I don't have the slide, but certainly ASV. There's good evidence on ASV in opiate use disorder and the breathing patterns in there. So certainly, I think the other important thing I like to think of when I see a patient like this is think about even if they have an old sleep study, ask them how much they were using when they did that sleep study. If that was a sleep study done when they were on methadone and now they're off methadone or on minimal methadone, and they had a ton of central apneas, those may be very well gone. So thinking you have to sort of meet the patient where they're at with their substance use. And so if they're now relapsed and using very significant amount of centrally depressing agents, like I've been trying to get them back in for repeat studies, but certainly you can consider ASV in these patients. It's not in this talk. I have one, but I know there is evidence on ASV in this patient population.
I think you're right. I think it is. I think CPAP, BiPAP, and ASV. And it's interesting to me is that ASV was not designed for this one. It was really for Cheyne-Stokes, is what it was.
Yes.
But it does seem more effective than either CPAP or BiPAP ST, which is so we clearly need more studies in that space. The other thing I've seen just is regardless of form of positive airway pressure, if patients actually have BIATS respiration, this ataxic breathing, that actually confers a poor response to PAP therapy. But in general, for mixed obstructive and central sleep apnea, which is very common, it can be very effective, ASV. I agree.
I think the hope is maybe for the right patient who has this, if GLP-1 therapy proves efficacious, if you have a patient who's obese, who has substance use but is getting sober, and then you can give them a GLP-1 that can really help treat multiple things, you might really be able to change a lot in their life. And so that was what I was so excited about when I saw this. And I know Dr. Wojak is on here, and he's like, Jen Langstengel loves GLP-1s, but I do.
It is amazing that it's an approved therapy for obstructive sleep apnea now, and that it may also be hitting addiction pathways or reward pathways in the brain, which is not surprising, but just incredible that this drug has so many different benefits. I'm so glad you included some of that data in your talk. One of the interesting things to me, and there was actually at the ATS this year, there was a scientific symposium that sort of paired a number of different causes of sudden death in sleep. So it included a talk about sleep apnea. It included SUDEP, which is a sudden unexplained death in epilepsy. It included congenital central hypoventilation syndrome, and it included opioid deficiency. And there's a lot of funding, as you indicated, for example, with the HEAL initiative, going into better understanding how we might be able to leverage, novel respiratory stimulants in the treatment of this. And what's interesting is that this may have relevance to some of these other causes of sudden death that maybe have at their basis hypoventilation.
Ventilation.
Yeah.
Yeah.
Which is sort of cool to think about. And one of the other things is we've been working in the space that I think is interesting is there are, sort of to that point, a number of preclinical studies looking at a variety of different respiratory stimulants, intranasal leptin, for example,
Leptin.
right? Yep. There's some ampakines. They're looking at even things like theophylline and caffeine. And so I think there is some hope that this sort of knowledge that we have around control of breathing and that gets impaired in opioid-induced sleep disorder breathing and overdose deaths. There may be some newer therapies down the line.
Yes, I took those out, but yes, intranasal leptin is definitely being studied as well. And it was one of the very interesting ones. I was like, ooh, I should pick what I want to talk about. And I was like, these two are on the market. I was like, so this is what we're going with.
Yeah,
but yes, no, there's hope that intranasal leptin and some of those others may also, and I think a lot of it's going to be sort of phenotyping our patients and figuring out which pathway they're going to go down, and then saying, oh, this patient, maybe they also need, you screen for their sleep ability to control their sleep environment, control their sleep, and you say, hey, maybe we need to work on this as well. And you sort of can start to do more personalized, tailored approach to care within their substance use treatment with personalized sleep care as part of this. I think that's probably, hopefully, what the future will look like. But I think
I agree. I think some of these drugs that are targeting, you alluded to a few of the specific nuclei in the brain, in the cortex, in subcortical regions in the brainstem that are become impaired with opioid overdoses, that targeting some of those with that activate those regions of the brain could be life-saving. Right now, it's naloxone that we have. And I think the other thing, that's interesting in this space is that, for a long time, we've been very good about measuring cardiac activity in terms of sudden cardiac arrest. But what we're seeing, I'm starting to see on the market right now are devices that can be placed on the chest wall that link to an iPhone, that if a patient overdoses and they start to sense hypoventilation, can trigger an EMS call. And, it's just this fascinating change of, monitoring respiration and breathing as a sensor to trigger EMS and maybe save someone's life who was overdosed unintentionally with these drugs, and so I think there's some digital wearable technology that is in that space. Again, I think could be transformational in the care of some of these patients. Well, I don't think we have any other questions. We're about 5 minutes to the hour. Jen, thank you so much for putting together.
Thank you.
This wonderful talk on a really important public health issue. And thanks, everyone. This is our last sleep seminar for the academic year, and we will return in September for the next academic year. Have a good summer break. Take care, everyone. Bye-bye.